No tengo conflictos de interés que reportar, sin embargo, es importante mencionar que yo soy ecocardiografista y por eso no realizo las demás técnicas de imagen, pero abordaré el contexto de las diferentes técnicas para el diagnóstico de la amiloidosis cardíaca. Desafortunadamente, no creo que sea capaz de hacer toda la presentación en español y por eso pasaré al inglés. Mis disculpas. Sin embargo, tendré todo el gusto de responder a sus preguntas en español al final de la presentación, así que empecemos. This is the summary of my presentation. Well, cardiac amyloidosis is a progressive infiltrative disease that affects several organs and tissues, such as the liver, the kidney, the peripheral nerves, and there is essentially an extracellular deposition of amyloid fibrils. There are three types: the AL type that results from the aggregation and fibril formations from monoclonal immunoglobulin light chain. Also, the ATTR type that results from the deposition of transthyretin. There are two types, an acquired type and an hereditary type. And also the AA amyloidosis that represents less than 2% of the cases and is secondary to inflammatory diseases with liver production of serum amyloid A. Just out of curiosity, in Portugal we have a specific hereditary ATTR amyloidosis that affects essentially the peripheral nerves that we call familiar paramyloidosis, and it's really a mutation from Portugal, from the north of Portugal, from Vila do Conde and Póvoa do Varzim. And as you can see, there are several cases widespread worldwide because due to migration since the 15th century. So this is a disease that you can find everywhere. This is an hereditary form. And 20% of the cases are located in the north of Portugal. I don't know if you have any here in Galicia, pero this is an example of an hereditary form of amyloidosis, but it does not affect usually the heart. So amyloidosis is a disease that with an extracellular deposition of amyloid, it can stay in biopsy specimens, it can be visible with the classic hematoxylin-eosin staining. However, it's with Conco-Red staining that we can see the specific deposition of amyloid, and it has a specific characteristic because under cross-polarized light, it has a specific green birefringence. Today, the biopsy specimens can also be processed with immunostaining with antibodies to anti-TTR, lambda, and kappa light chains. And there are also other techniques such as direct immunofluorescence, immunoelectron microscopy, and mass spectrometry that can be, in this very comprehensive algorithm, allow a more specific diagnosis from biopsies. However, I'm here to talk about imaging. Usually patients are referred due to symptoms of heart failure, usually HFpEF, or it can be an incidental finding in imaging, usually echocardiogram. It's important when we evaluate those patients to check for red flags, clinical red flags such as bilateral carpal tunnel syndrome, more frequent in ATTR cardiac amyloidosis. This is a curious phenotype of that represents a rupture of biceps tendon that it's called the Popeye sign because it looks like Popeye. For those who know what Popeye is. Spinal stenosis is another form of presentation, neuropathic pain, orthostatic hypotension, periorbital petechia, macroglossia. It's usually associated with aortic stenosis, especially low flow, low gradient, and we have an hypertrophic cardiomyopathy that is diagnosed after the 6th decade of life. We need to think about the possibility of amyloidosis. In the electrocardiogram, we have a pseudoinfarct pattern, AV block due to involvement of the conduction system. There is a normal ratio between increased left ventricular thickness and low QRS voltage because in amyloidosis there is an increase in left ventricular mass, but electrocardiograms show low voltage ECG. But it's present only in 20% of the ATTR patients. And in fact, left ventricular hypertrophy is only present in 20% of the patients. So this is not a very helpful, it can increase the suspicion, but it's not a very specific form. There is a high prevalence of atrial fibrillation that will predispose to thromboembolic events. Blood tests are very important because we need to identify in the AL form in the protein electrophoresis a demonstration of a monoclonal band, as you can see here, and there's also an abnormal free light chain kappa lambda ratio. It's usually frequent an increase in NT-proBNP and in troponins. When the increase is higher, it represents a more severe form of amyloidosis. Now talking about imaging and regarding echocardiography, there is usually an increase in left ventricular relative wall thickness and in mass with a wall thickness above 12 millimeters with this specific granular sparkling feature. The left ventricular cavity size is usually normal or small, and stroke volume is often reduced. The right ventricular ejection fraction and right and left ventricular ejection fraction are usually at the beginning preserved. There is an abnormal longitudinal function, both of TAPSE but also MAPSE. But with long-standing disease, the left ventricle can enlarge and systolic dysfunction will ensue. There are also amyloid infiltration in other parts of the heart. We will have a thickened right ventricular free wall, a thickened interatrial septum, thickened valves. There is also precardial effusion quite frequently, biatrial enlargement, and left ventricular diastolic function impairment with grade 2 or above, reflecting a restrictive filling pattern. An increase in estimated pulmonary artery systolic and right atrial pressures. So these are images from extreme cases of amyloidosis, quite characteristics with an increase in thickness of the left ventricular wall with this sparkling pattern that you can see here that is quite suspicious of amyloidosis. With Doppler, we can see this restrictive pattern, and this is an example of a reduced MAPSE in patients with amyloidosis. That's measured in the same way as TAPSE. But we need, in those cases when we see that, it's important to perform an advanced echocardiography study with tissue Doppler imaging, where we have a mitral and tricuspid annulus TD velocities that are substantially reduced, usually below 5 centimeters per second, and an increase in mitral E over E prime ratio, reflecting the increase in left ventricular filling pressures. With 2D speckle tracking echocardiography, global longitudinal strain is usually compromised. There is an apical sparing type that I will show in the next slide that we can see in the strain polar plot mapping. Right ventricular longitudinal free wall strain is also compromised. A reduction also in left atrial strain in all phases, reservoir conduit and contraction phases that shows a higher accuracy for amyloidosis. And there is also sometimes in 20% of patients an atrial electromechanical dissociation. That is, a patient can be in sinus rhythm. However, when we do strain imaging, there is no effective atrial contraction. So he is in sinus rhythm, but there is no contraction of the atrium. 3D echo can also be useful to measure volumes, mass and strain. These are examples of TDE of mitral annulus. As you can see, velocities are very, very low. The polar map, as you can see, you can call it the cherry on top of the cake because the apical segments are with a preserved strain, but the medium and basal segments, the strain is very, very compromised. So this is an apical sparing pattern that we have described. We can also measure right ventricular strain and left atrial strain that is also involved. For several years now, we have described this apical sparing pattern, and there are several markers, such as this one. These studies from 2013 that show that in the apical segments, from the apical septal apical segments, the strain is preserved, but not in the mid and the basal segments. So this is the ratio of the apical to basal septal strain, and this has a very high predictive accuracy for cardiac amyloidosis, and this is a cutoff, 2.1%, and as you can see, patients with cardiac amyloidosis have a substantial increase in this ratio. So this has been used for several years, and many other parameters related to this apical sparing, the relative apical sparing this ratio, also the one that I've just mentioned, and in a head-to-head comparison of conventional and also strain-derived parameters, the ones with strain have a high predictive accuracy for amyloidosis. So this has been used for many, many years. And as you can see, when we have a severe progression of the disease, with high burden of amyloid deposition, that's when we have a compromise of left ventricular ejection fraction and TAPSA, but with strain we can detect it at low burden of intermediate burden of amyloid deposition, so they are much more, they can detect amyloidosis earlier. Moving on to cardiac MRI, as you know, it's a gold standard to evaluate anatomical and function. It is a non-invasive imaging modality that allows for tissue characterization. And what is important is that the amyloidotic myocardium has a high avidity for gadolinium. So the late gadolinium enhancement pattern is typically global and subendocardial, becoming transmural when we have advanced stages. It is more extensive and more frequently transmural in the ATTR form compared to the AL form. We can also have late gadolinium enhancement involving the right ventricle, but only more frequent in ATTR amyloidosis also. We can do a native T1 and measure the extracellular volume that are increased in patients with amyloidosis. And in the same way as in echo, we can also assess myocardial deformation parameters, both longitudinal, radial, and circumferential strains that are impaired, being the basal segments more involved as in echocardiography. This is an example of CMR with left ventricular hypertrophy, also hypertrophy of the right ventricle, and an extensive deposition of extensive late gadolinium enhancement that also involves the interatrial septum. Native T1 and that can be done without contrast and extracellular volume are indeed two important markers of amyloidosis, and they have a very high predictive accuracy for diagnosis of both AL and ATTR cardiac amyloidosis. So cardiac magnetic resonance is a very important tool for the diagnosis, and in my opinion, every patient with a suspicion of amyloidosis should undergo a CMR. And there are also specific cutoffs for native T1, for instance, that can rule out or rule in the possibility of cardiac amyloidosis. But as you can see here, amyloidosis is quite different from the other diseases because it has a very high native T1 values and also a very high extracellular volume. So it can be very, very helpful for this diagnosis. In this example, for instance, compared to hypertrophic cardiomyopathy and HFpEF, we have a very high native T1 and very high extracellular volume. So this can be, and also late gadolinium enhancement. So this can be very helpful for to support diagnosis of amyloidosis. This is an example from our center with a patient with an increased native T1 mapping and also 44% of extracellular volume that is detected after contrast. And this is the strain that is also measured in CMR. Regarding nuclear medicine, we usually perform cardiac scintigraphy with bone tracers that is very specific for ATTR. We have radio, the tracers that we can use is PIP, HMDP, or DPD. It's essentially the same. It depends on local availability. I think that DPD is most used in many centers. We use DPD for our patients. The uptake of these radio tracers that are specific for bone is related to the high calcium content of TTR fibrils compared to AL fibrils, becoming not only a sensitive but also a specific test for the diagnosis of ATTR, cardiac amyloidosis. We use the Perugini method that I will show in the next slide that compares the uptake between the myocardium and the bone, and it can be graded visually with the Perugini system. We can also use a ratio of heart to contralateral uptake, and a ratio greater than 1% is also suggestive of ATTR cardiac amyloidosis. There are all other investigational alternatives. but that are not yet in clinical practice. The PET with other tracers, and also Imagen cardiac scintigraphy that will allow the amyloid infiltration of the sympathetic nervous system. This is the heterogeneous score, as you can see. With 0, there is no cardiac myocardium uptake. With 1, there is some cardiac uptake there. Grade 2, much more cardiac uptake, and grade 3, an intense cardiac uptake of DPD. Finally, multi-detector computed tomography is not yet fully validated for clinical practice in the context of cardiac amyloidosis. However, today it can be used as an alternative to CMR, particularly in patients with contraindications such as non-compatible pacemakers, renal failure requiring dialysis, and claustrophobia. And it's essentially because iodine-based contrasts have a similar kinetics compared to gadolinium-based contrasts, and we can, in the same way, obtain a late iodine enhancement, but with current equipment, there is low spatial resolution that, however, has been improving with new scanners. And it also is possible to obtain relevant information regarding myocardial perfusion and expansion of extracellular volume. These are 2 examples that compares head-to-head CMR and CT with late gadolinium enhancement and late iodine enhancement. As you can see, they are exactly in the same location. So this can be in the future an alternative when patient cannot undergo CMR. And this is a CT perfusion imaging that at the end it's possible to measure extracellular volume that, as you can see, participants with cardiac amyloidosis have an increase in this extracellular volume in all segments compared for patients with a simple non-amyloidotic hypertrophy. It's possible with imaging differentiate, not completely, with completely accuracy, but patients with ATTR cardiac amyloidosis usually have an asymmetric increase in left ventricular thickness, a higher left ventricular mass index, the involvement of the right ventricle and right ventricle strain are usually more compromised. Also of the apical left ventricular strain is usually more compromised, and a worse left atrial reservoir and pump function in ATTR. The same is observed in cardiac MRI, higher left ventricular mass, more amyloid deposition, higher extracellular volume, and worse left atrial function. And with bone scintigraphy, if we have a heterogeneous score grade 0 to 1, it's probably more AL amyloidosis, but grade 2 and 3 of the heterogeneous score are very specific for ATTR cardiac amyloidosis. So this is more or less our algorithm for diagnosis. We have to have a complete clinical examination to check for red flags, an ECG, echocardiogram, all the patients, whenever possible, if there is no contraindication, underwent also a CMR. It's important to perform hematological tests in those patients to check for the serum free light chain assay and protein electrophoresis. To differentiate between AL and ATTT amyloidosis, they also perform a bone scintigraphy. So if we have a grade 0 and a monoclonal band, 0 or 1 with a monoclonal band or free light chain abnormality, it's usually in AL. If we have a grade 2 and 3, it's usually ATTR amyloidosis, and the patient needs to do an TTR gene sequencing to check if it's the wild type or the mutant type ATTR. So what is the latest research in cardiac amyloidosis imaging? Regarding diagnosis, we know now that the relative apical sparing pattern and all the ratios that are derived from this, based on this assumption, is not as accurate as we believed before, because if you can see all those ratios that derive from this apical sparing, they have a very modest predictive accuracy of 0.60, 0.70, so they are not very, very accurate for the diagnosis. These other studies showed the same, with a modest predictive accuracy of apical sparing ratio, and this pattern is present in 1/3 of patients without cardiac amyloidosis with a similar clinical presentation, and even in 1/10 of healthy individuals. So this can point us to this possible diagnosis, but is not very specific and sensitive for the diagnosis. So there is, as an alternative, several scores have been developed to overcome this problem and to increase the possibility, the predictive accuracy of echocardiography, and there is the systemic AL score that includes relative wall thickness, E ovary prime, TAPS, and longitudinal strain for patients with systemic amyloidosis to check if there is cardiac involvement, and the increased wall thickness score for patients with an increased wall, with increased walls, usually at the ATTR form, that uses relative wall thickness, E ovary prime, TAPS, longitudinal strain, and septal to apical, apical to basal longitudinal strain ratio. However, a new score has been also tested, the Amiloidosis score, that is a simple ratio only with relative wall thickness and E ovary prime. It's easier to analyze. That's increased in patients with cardiac amyloidosis, both with AL form and the ATTR form, and it performs quite similar to the ones that I've mentioned before, the AL score and the EWT score. It has quite a similar predictive accuracy with only two variables. Also, the analysis of this study analyzed all the strain parameters from all chambers, right ventricle, left ventricle, right and left atrium, and it was abnormal in every chamber. However, they were more abnormal at the left atrium, and the left atrium reservoir and contraction strain are compromised, and they were independent predictors both for cardiac amyloidosis and more significantly to ATTR form. So left atrium strain is more specific of abnormalities, is more specific of cardiac amyloidosis. Also, right ventricular fugal strain, when we had this parameter to the left ventricle relative apical sparing, it can also improve prediction for cardiac amyloidosis. It's another parameter that we can associate with other parameters to increase the predictive accuracy. And we have now other diagnostic alternatives. On the left panel, there is the possibility to use this radiotracer evusamitide that can be helpful in PET scan because it has a high avidity for cardiac amyloid, and it can be helpful for diagnosis of amyloidosis. And there is also the possibility to echocardiography to do the septal reflectivity ratio, because in ATTR there are microcalcifications at the septum that will increase this septal reflectivity ratio between the septum and the posterior wall. As you can see in the lower panel, it is increased in ATTR form due to those microcalcifications of the septum. So these are new options for the diagnosis. As for prognosis, stroke volume index is an important prognostic marker, even in models that include left ventricular strain and other markers. So these can be useful for assessing prognosis. Also, the global radial strain and circumferential strain that have an increased gradient between the extracellular volume 1 indicates low amyloid accumulation, and the fourth quartile it's a high accumulation. It has an important gradient, and it's very helpful for prognostic effects, both radial and circumferential strain and mortality. Right ventricular to pulmonary artery coupling has been used today in many studies where it showed important prognostic effect, and also in amyloidosis it has been tested. This ratio, we can calculate this coupling non-invasively with the TAPS over pulmonary artery systolic pressure, and this cutoff of 0.45. It has a prognostic. It can differentiate patients with a worse prognosis compared to patients with a better coupling. And also another radiotracer, a floor beta peer that has a possibility to link to it has an affinity for amyloidosis. It can also, the amount of this tracer can also be helpful for prognostic effects. As for treatment response, for instance, in patients treated with ATTR, cardiac amyloidosis treated with tafamidis, we know that when there is a lesser deterioration of GLS and myocardial work index and myocardial efficiency over 12 months, when the treatment is being done, they have a better prognosis. And on the right-hand side, you can see that the response can be different if the patient is in sinus rhythm or in atrial fibrillation. If the patient is in sinus rhythm and is being treated with tafamidis, the strain of the left atrium usually improves. The GLS not so much, but when the patient is in atrial fibrillation, the response is usually much worse. There is no improvement and can even be some worsening in the condition. So patients in sinus rhythm respond better to tafamidis treatment. Also in the AL form, when we have patients that respond to the hematological treatment, there is improvement in GLS and in myocardial work. And if there is an improvement with treatment, there's also a prognostic implication. We can also measure extracellular volume with cardiac MRI in the patients that under treatment stabilize or decrease this extracellular volume. They have a better prognosis compared to the ones that don't have this, there is an increase in extracellular volume. So this can be an indication if the patient is responding well to treatment or not. This other study compared the response of patients not only with cardiac amyloidosis, but also with involvement of the spleen and the liver. And they have shown that under treatment, if the patient, the response, the liver and the spleen response with reduction in extracellular volume is usually it's faster compared to the response of the heart. And this can also be an indicative of a good response. Finally, and because I'm a clinical cardiologist, I will just briefly talk about the relation between cardiac amyloidosis and aortic stenosis, because when we do echocardiograms, you know that patients with severe aortic stenosis, it's quite frequent to find this relative apical sparing pattern, and we really don't know what to do when we have that pattern. This study studied patients with severe aortic stenosis that were referred for surgical replacement of the aortic valve. And this is a very comprehensive study. All patients underwent CMR, and they have shown that none of the patients, they have a relative apical sparing. That's what we see in some patients. So severe aortic stenosis and relative apical sparing. They underwent CMR, and none of them had a suspicion of amyloidosis at CMR. And they also studied biopsies that were obtained during surgery, and none of them had amyloid deposition. So this is really not specific for patients with amyloidosis, the presence of this relative apical sparing. And more importantly, after surgery, this relative apical sparing reduced. So this is usually reversible after surgery when we find this in patients with severe aortic stenosis, and it doesn't necessarily imply that the patient has a cardiac amyloidosis. And I wouldn't be fair if I wouldn't mention your own study that you performed here with a similar cohort of patients, but those patients underwent TAVI. In fact, they were studied with DPD, scintigraphy, and only 7% of patients with severe aortic stenosis have a DPD grade of 2 and 3, which really represents a very small number of patients with apical sparing that have this possibility of cardiac amyloidosis. But the relative apical sparing was more prevalent in patients with both aortic stenosis and cardiac amyloidosis, 70%, but still 44% of the patients without cardiac amyloidosis with aortic stenosis alone have this relative sparing. So this is really not very specific. And as I've shown in the previous slide, it can be reversible in most of the cases after treatment of the aortic stenosis. And you have developed this score that has a high predictive accuracy with age, relative apical sparing, the peak gradient, and left ventricular mass index to help to differentiate patients with the possibility of having cardiac amyloidosis. But relative apical sparing is really very frequent, including in patients with severe aortic stenosis, and it does not. So it is not clear that those patients really have cardiac amyloidosis. In the future, there are other possibilities. Myocardial work, as I mentioned in some previous works, can be useful for the diagnosis and prognosis, for the MRI fluid dynamics, diffusion tensor CMR, and also some studies with machine learning that show the added prognostic value on top of native T1 are being studied. So my take-home messages are that amyloidosis has been increasingly recognized. There has been improvements in multimodality imaging that allowed not only a better identification, but most importantly, early identification. Biopsy is today used in only very specific circumstances. The treatment depends on a correct diagnosis and correct identification of the cardiac amyloidosis subtype, and a multimodality imaging pathway is always necessary when we have a patient with a suspicion of cardiac amiloidosis. Muchas gracias por su atención. Si tiene alguna pregunta, estaré encantada de responder.
Muchas gracias, Ana, por esta exposición, este resumen un poco de la situación actual del diagnóstico, del papel de la imagen multimodal, no solo en el diagnóstico, sino un poco en el seguimiento clínico de pacientes con amiloidosis. Yo creo que ese es un reto, e incluso es un reto cómo seleccionar las técnicas, qué técnicas hacer, a qué pacientes. Obviamente, en quién es posible, si sería posible quedarse solo con el eco en el conocimiento actual, en quién hay que progresar, obviamente, más allá de la escintigrafía como gold estándar un poco para el diagnóstico con otro tipo de técnicas. Yo creo que es muy interesante este aspecto. Estaban teniendo problemas de conexión los colegas del 12 de octubre para hacer las preguntas y, por tanto, vamos a empezar. Nosotros, si alguien tiene alguna pregunta o algún comentario, yo creo que estaba por aquí también María Bastos, que nos ponías el paper que ella ha liderado y que realmente es una gran contribución en el ámbito de la estenosis aórtica y la amiloidosis y un poco el papel del apical sparing, es decir, de la imagen clásica de eco. No sé si María quieres hacer algún comentario, alguna pregunta.
Veíamos nosotros en concreto en estenosis aórtica, ¿no? Este es un escenario muy difícil para activar amiloidosis, ¿no? Porque son pacientes que tienen un fenotipo similar. Y nosotros encontrábamos que cuando empezamos el trabajo esta baja sensibilidad y especificidad del relapse, que hasta ese momento era como casi el estándar de eco para definir a aquellos pacientes que podían tener amiloidosis. Pues son estos escenarios que realmente, además, la estenosis aórtica tiene una prevalencia mayor de amiloidosis igual que la población general, ¿no? Y que se cree que puede ser un facilitador del depósito de amiloide. Creemos que es un escenario difícil y es un escenario importante para activar, ¿no? A los pacientes con amiloidosis. Aparte, desde el punto de vista epidemiológico, también comparte con características de pacientes mayores y nosotros hemos publicado este score específico en estenosis aórtica. Ya el GAIS había publicado un score más clínico, este es específico de Imagen, un poco para dar el salto del eco a las otras técnicas de derivado, ¿no? Me gustaría saber si en vuestro centro, ¿no?, os basáis solo en el eco para derivar a los pacientes, para el cuidado de la amiloidosis, y cómo trabajáis concretamente con los estenosis aórtica, ¿no?
En estenosis aórtica, sí, como ha dicho, es muy, para una persona que hace muchos ecos en pacientes con estenosis aórtica, es muy frecuente encontrar este padrón de apical sparing. And nosotros no sabemos si es muy importante o no. con el primer estudio que yo había mostrado en la presentación, nos ha tranquilizado un poco, porque los pacientes en la resonancia y también en la biopsia no han demostrado la presencia de amiloidosis. Esto era algo que es reversible. Pero nuestra opción ha sido tratar al paciente con TAVI o cirugía, y si el padrón no ha mejorado después del tratamiento, entonces es importante hacer la evaluación para excluir la presencia de amiloidosis.
Posponéis el cribado a el remodelado reverso, ¿no? A ver si hay un remodelado reverso de ese patrón.
Sí, si el padrón ha mejorado después del tratamiento. Pero otras veces es tan sospecho que una enorme hipertrofia, ahí avanzamos de inmediato con el estudio, pero a veces hay solo un poquito de hipertrofia, un poquito de granular sparking, un poquito, el epical sparing no es tan claro, pero sí es. Por veces, los ejemplos que voy a mostrar, si tengo un paciente como eso, es obvio que tiene que avanzar por toda la investigación de amiloidosis, pero los otros casos hacemos el tratamiento primero y después, si no ha mejorado, hacemos la investigación después.
Y eso en tu práctica, ¿cuánto representaría de proporción de pacientes con estenosis aórtica en donde el eco podría sugerir amiloidosis no segura y esperáis a ver qué sucede después de la reparación o del recambio valvular?
Estenosis aórtica no es muy frecuente, esos casos extremos que he mostrado, con una grande hipertrofia, no es muy frecuente. Es habitualmente
es decir, que en la mayoría...
una hipertrofia ligera, moderada.
En la mayoría esperáis, entonces, en la mayoría esperáis a sustituir la válvula y ver qué sucede con la imagen del eco o con el eco.
Si el paciente tiene una doença hematológica...
Ya, no, pero obviamente, pero en la mayoría de los casos que pueda haber una cierta sospecha, esperáis a ver qué sucede una vez que intervenís. Es muy, muy interesante.
Solo tenemos 2 días de resonancia, pero no es posible hacer tantos pacientes.
No sucede a todos.
Los pacientes con estenosis aórtica no es posible. También no tenemos medicina nuclear en nuestro hospital. Tenemos fácil acceso, pero es necesario pedir para el exterior.
La medicina nuclear.
No es posible hacer a todos los doentes con estenosis aórtica si tenemos una sospecha. Tenemos que los seleccionar muy bien.
Alfonso, y luego el 12 de octubre, ¿qué quiere preguntar? Sí, no, pero haz.
¿Crees que alguna técnica de imagen nos va a poder ayudar, sobre todo en esa capacidad de predecir la respuesta al tratamiento? ¿En qué pacientes la respuesta?
Al inicio no. Cuando empezamos el tratamiento, que lo conozca, que no conozca, no hay ninguna posibilidad de predecir la respuesta. Pero durante el tratamiento, la resonancia permite, si extracellular volume no ha mejorado en los primeros tiempos del tratamiento, es un señal que probablemente el paciente no va a mejorar. Y también los otros parámetros de strain, de aurícula izquierda, del ventrículo, se no ha mejorado mucho. Pero como ha dicho si el paciente tiene fibrilación auricular, la mayoría no tiene muy buena respuesta al tratamiento, pero no es eso que va a impedir de tratar los pacientes, pero
Sí, ese es un debate.
Es una indicación que probablemente no va a tener mucha buena respuesta, pero no vamos,
Sí, sí.
solo con estos estudios, no tratar a los pacientes porque están en fibrilación auricular, porque es muy frecuente.
Sí, pero monitorizar la respuesta puede ser un futuro, porque claro, el tratamiento tiene un coste enorme y sabemos que hay pacientes que no responden. El problema es cómo identificar a esos pacientes que no responden para no seguir tratándoles con algo que tampoco va, parece. El 12 de octubre, ¿quieren hacer un comentario? Juan.
Buenos días, José Ramón, soy Carmen Jiménez.
Hola, Carmen.
¿Me oís?
Sí,
¿Qué
sí,
tal?
perfecto.
Primero de todo, felicitar a la doctora Timoteo por la charla, ha sido espectacular. Yo que me dedico a la imagen, pues ha sido muy integradora. Y también como clínica, como decía ella, muchas veces, y siguiendo tu estela, José Ramón, cuando decías que en algún momento hay que decidir qué técnicas hacemos, ¿no? Inicialmente, muchas veces tenemos una sospecha diagnóstica de amiloidosis, hacemos el eco y la gamografía nos muestra un Perugini 3. Aquí paramos, ¿no? No hay que hacer resonancia a todos los pacientes, lo que decíamos antes, ¿no?
En mi hospital, todos los pacientes con la sospecha hacen una resonancia. Es muy importante para el diagnóstico. Y como ha dicho, la resonancia tenemos en nuestro hospital, pero no la cintigrafía. También hacemos la cintigrafía para confirmar que no hay la forma ATTR, pero intentamos que todos los pacientes tienen una evaluación completa con eco, resonancia, estudio del hematológico, también es muy importante, de cintigrafía. Intentamos que todos los pacientes tienen posibilidad de hacer todos los exámenes.
¿Cómo hacéis en el 12? ¿Hacéis también a todos resonancia?
La imagen está parada.
Está congelada, no sé,
No.
es que tienen un problema de...
No sé si han oído mi...
¿Habéis oído la respuesta de Teresa?
Pero sí, no nos ven.
Sí, ver te estamos viendo, casi solo...
No,
Sí.
hemos tenido un apagón, José Ramón, y no hemos podido oír la respuesta. Nada, no os preocupéis por nosotros.
Voy a repetir. Intentamos que todos los pacientes en nuestro hospital hacen la evaluación completa, porque es muy importante. Es más fácil hacer una evaluación completa do que hacer una biopsia, por ejemplo. Por eso es muy importante intentar hacer el diagnóstico más completo posible, evitando hacer una biopsia miocárdica, porque es más complicado, tiene más riesgos. Siempre que posible intentamos que faça eco, resonancia, el estudio hematológico y la cintigrafía.
Carmen, en el 12 también hacéis a todos resonancia.
Intentamos hacerlo a todos, pero es verdad que estamos con una disponibilidad también reducida y el paciente obviamente entendía que se había hecho el despistaje de AL con la banda neuronal, pero la idea es que muchas veces todos no es posible y seleccionamos al subgrupo de pacientes que pensamos que se pueden beneficiar de tratamiento también. Pero es verdad que ojalá pudiéramos hacerlo a todos, como dice Teresa.
Porque para iniciar el tratamiento, si es una TTR amiloidosis, es muy importante confirmar el diagnóstico, pero todos tienen que hacer una resonancia para un correcto diagnóstico y saber si es mismo una amiloidosis cardíaca.
Sí, supongo que para confirmar, es decir, para aprobar el tratamiento, incluso para que financien el tratamiento, es necesario tener una resonancia. Pero bueno, ahí también entraría un poco la idea de cuántos falsos negativos, es decir, al final con la resonancia aparecen en sospechas de amiloidosis, porque ahí lo que habrá es que aclarar y aquilatar muy bien cuál es la indicación, porque si para toda sospecha de amiloidosis pues se pide
con la clínica, con ecocardiograma, el electrocardiograma y con eco,
con eso ahí está un poco la indicación.
Podríamos tener una sospecha.
Y ahí la sensibilidad sería muy alta para la confirmación diagnóstica. Sí, yo creo que es importante primero para caracterizar el diagnóstico y de alguna forma también para lo que ahora nos viene. Tenemos tafamidis, en breve vamos a tener acoramidis, vamos a tener nuevas alternativas terapéuticas y al final vamos a tener que seleccionar qué fármacos a quién, pero obviamente habrá que seleccionarlos porque estos fármacos también tardan al menos un año en que su efecto aparezca, no es una cosa inmediata. Y ahí está un poco la expectativa de vida también del paciente, porque si un fármaco tarda un año al menos en demostrar algún tipo de beneficio, pues también eso debe pesar en la selección de los pacientes, ¿no? Porque no es una cosa inmediata de que el efecto lo ves al día siguiente, sino que por lo menos tarda un año en empezar a separarse las curvas, ¿no?
Para la reducción de la deposición de amiloides.
Es anterior.
Tiene que la respuesta, como he dicho, resonancia permite ver la reducción del extracelular volumen, que es un marcador de la respuesta.
Muy bien, yo creo que es un tema fascinante, ahí está, es decir, pensábamos que era una enfermedad rara y no es una enfermedad rara, al final es una enfermedad relativamente prevalente.
Con los medios de imagen, hoy tenemos muchos más casos.
Claro, el problema es cómo emerger y otra cosa es cómo organizar la atención a estos pacientes, ¿no? Cuando era una enfermedad rara, parece que había unidades de unos pocos ahí que llevaban unos cuantos casos.
Hoy tenemos un grupo dedicado a las cardiomiopatías, pues la cardiomiopatía hipertrófica, la amiloidosis, de todas las cardiomiopatías, un grupo con 2 o 3 personas que están dedicadas a esta.
Yo creo que incluso va a trascender a eso porque la dimensión de la amiloidosis es mucho mayor de la que esperábamos y no va a poder manejarse con 1 o 2 personas en centros grandes. Va a tener
algunos de los casos son diagnosticados por sospechos, por los colegas que hacen la consultación de cardiooncología, porque le reciben muchos oyentes con doenças hematológicas, que es la forma a él, pero muchos de los casos vienen de los colegas de cardiooncología que también siguen estos
pacientes. Perfecto, muchas gracias.
Ha sido un placer.
Ana, un placer y una presentación fantástica.
Bueno, muchas gracias. Un saludo.
Y gracias al 12 de octubre también.
No, adiós, adiós.
Hasta luego. Hasta luego.